Okay, good evening to this edition of ISG Kerala PG Masterclass. Right now we are having approach to clinical symptomatology, and today we have discussion on approach to diarrhea. The chairperson for today's session is Dr. Sunil K Mathai, Senior Consultant, Medical Trust Hospital, Ernakulam. I'm very glad to welcome Dr. Sunil Mathai, and I also like to proudly say that he is my first full-time student. I'm very happy that he is a very astute clinician and endoscopist, EO specialist, and he is doing a wonderful job. And he is also having DRNB program at Medical Trust, I think, for the last 15 years or so, I think so. Okay.
Yeah,
and
thank you.
Yeah. Along with me, Jayanthi ma'am also will be there. Jayanthi ma'am, are you there? Ma'am said she will join. And today the presenter is Dr. Ayisha, senior resident from Baby Memorial Hospital, Calicut. And the discussants are Dr. Zhumu, Mahsi from M, Chennai, and Dr. Muthukrishanan from SRM, Chennai. So once again, welcome the chairperson, the presenter, the discussant, and all the residents and Jayanthi ma'am to this session. Over to Dr. Sunil Mathai.
Hi, everybody. It's nice to be back in the academic sessions again. It was very difficult for me in Cayman Islands to get access to all these things because of the time zones. But it was fruitful in another sense. And approach to chronic diarrhea is probably one of the basic discussions which follow in symptomatology. I understand you're doing the approach to diarrhea, so it might include approach to acute as well as chronic diarrhea. Dr. Ayisha, are you the first year resident, second year resident, or the final year?
Currently, second year resident, sir.
Second year resident, yeah. So you would have finished the symptomatology. I think you could start the discussion and we'll get down into the topic. As the topic progresses, we'll have an interaction.
So please our plan is to have a case-based discussion. So we'll have a case and Dr. Ayisha will be presenting and we can actually ask clarification in between. It will be a very brief presentation and followed by the discussion of the symptomatology by the two other discussants. And in the end, we will arrive at a professional diagnosis. Then we will jump on to the theoretical aspect of how to approach. This is how we are going to do. Okay, Dr. Ayisha, please.
Good evening to all. My topic is approach to diarrhea. So first I will be presenting a case. So this is about a 33-year-old male from Calicut who is working in Merchant Navy, and he was traveling with the recent history of traveling to Europe and West Indies, and returned to India just 2 days back. He came to us with the chief complaints of increased bowel movement since past 4 weeks, with blood in stool since past 2 weeks, and lower abdominal pain in past 2 weeks. So history of presenting illness. He presented to us with increased frequency of bowel movement since past 4 weeks, which was abrupt in onset, associated with change in the form of stool, which according to the description was Bristol 6 or 7. He had 4 to 5 episodes per day of watery small volume stools, preceded by lower abdominal cramps and associated with urgency and tenesmus, and the pain subsided with passage of stools. He then experienced a sense of incomplete evacuation and subsequently had more episodes of blood intermixed with yellowish stools. He also gives history of fatigue and loss of appetite, and there was no history of any significant loss of weight, and there was no history of prior constipation. There was no history of any nocturnal episodes of diarrhea, and there was no history of any vomiting or abdominal distension. He did not give any significant drug history. His symptoms did not relieve with fasting, and he did not give any history of flatulence or borborygmi. There was no history of any excessive thirst, giddiness, or reduced urine output or altermentation. There was no history of contact with a similar case, and no history of any clustering of similar symptoms. No history of swelling of leg or altered taste or pigmentation of skin or reduced vision, bone pain, or any bleeding diathesis. There was no history of any high-risk behavior, blood transfusions, or tattooing in the past. No history of any fever or joint pain. There was no history of cough, hemoptysis, or evening rise of temperature, or any history of past tuberculosis or contact with TB. He did not give any history of oral or genital ulcers or skin lesions. There was no history of any antibiotic use prior to the onset of disease or any history of abdominal irradiation. He consulted a hospital in Barbados while he was traveling for the symptoms, and he took IV medications for the same. He also underwent abdominal imaging from there, and then he came here for further evaluation and management. There was no past history of any similar complaints, and he does not have any comorbidities, no history of any diabetes mellitus or hypertension, no past history of any abdominal surgery. Coming to personal history, he consumed a mixed diet. His appetite was reduced. He did not have any history of any substance abuse. His sleep was normal, and he belonged to the socio-economic status of upper middle class. Dietary history, he consumed a normal diet. He gives a history of normal protein and calorie intake despite of loss of appetite. Family history is a third child of a non-consanguineous marriage. There was no history of any similar complaints in the family. So summary would be a 33-year-old male without any known comorbidities with features of small volume bloody diarrhea 4 weeks duration, which was associated with periumbilical colicky pain without history of significant weight loss or features of malabsorption or any bowel obstruction.
Okay, we would ask the discussants to discuss the case. Dr. Zhumu, Mahsi, and Dr. Muthukrishanan. Are you there?
Yes, sir. Yes, sir.
Yes, sir.
Okay, you can actually ask for clarification if you want any clarification on the history. Dr. Sunil Mathai, you can also continue with the class, asking clarification if there is anything in the history which is to be added in.
You said he was the patient was in the merchant navy. So what they do normally is they travel in the ship for a long duration and alight for 1 or 2 days in the dock. So what was his last docking prior to the diarrhea?
It was in West Indies, Europe and West Indies, followed by West Indies.
So when you said it was a 4-week duration diarrhea, so just prior to that, when did he dock? I mean, was it just prior to a day before or 1 week before? Because this is a 1-month diarrhea. So when
He
did he dock?
returned to India just 2 weeks prior to the presentation, sir, just 2 days prior to the presentation. And previously that he was in West Indies. He went to a local hospital in Barbados, and then he came back to India just 2 weeks prior to the presentation.
So
2 weeks or 2 days? 2 weeks or 2
2
days?
days, sir. 2 days. 2 days.
So entire symptomatology began after landing in India. Is that correct?
No, sir. 2 days prior. The symptomatology began when he was traveling.
So no, we have a little confusion. The total illness is 4 weeks duration. Okay. Since when he started noticing blood?
2 weeks, sir.
2 weeks. So after 2 weeks of the onset of illness, he noticed blood. Okay.
Yes, sir.
The question was that how many days after landing in a port this symptomatology began? That's what Dr. Sunil Mathai was asking. Am I right, Dr. Sunil?
Yeah, I wanted to know the last docking point and what was the onset of illness after the last docking point?
Yeah. How many days approximately after the what we are what is the importance of that question, Dr. Ayisha?
So the place from where he acquired the disease?
Yeah, we presuming that it may be an infection. We are thinking that probably he would have landed, no, they may not be eating fresh food and all. They will be actually mad to eat all type of food when they reach a port, and they will be roaming around in that city or town. They may be eating everything available, and probably they get an infection as well. Okay. So that whether it fits in with an incubation period, because they will be in the ship for quite a long period. Usually it takes weeks before they land on another area. So that is the importance of that, because well, it is not that they will not develop an infection in the ship, but it is more likely when they reach the land. It is more likely.
If he had developed an infection in the ship, other people would have been affected because they eat a common mess.
Definitely, because it will be a sort of if the cook is having the infection or someone else is having the infection, it's likely that others would have known. And being a small community, everybody will be knowing. The ship doctor will be definitely knowing and warning and everything. So that probably did not occur. Okay, Doctor Zhumu, Mahsi, Dr. Mahsi.
Yes, sir.
Yes, sir. Please
Yes,
tell
sir.
us. Yes.
Sir, I would like to know, besides this antibiotic history, any other NSAIDs, any other drugs?
No, there was no history of any other medication.
You want to know the history of medication after the illness or before the illness?
Before the illness, sir.
Any particular one in your mind?
NSAIDs, then ARBs. Yeah, NSAIDs, ARBs. And yeah.
No, sir, there was no
Is
history
there
of
any particular drug in your mind? Which drug you are trying to figure it out? You are considering, you want to entertain what possibility? Okay, Dr. Ayisha told there is probably no NSAIDs.
Yes, sir.
Yes, sir. Okay. And I think that's all.
So I want to know about any consumption of improperly cooked fish or any food habits in the.
No,
That is undercooked fish or uncooked fish or something, strange food or something. Dr. Ayisha, do you have any information?
No, sir, there was no history. There was no such history.
What is the type of food they're taking in the fish? Canned food, freshly prepared meal? Can you highlight on that?
Sir, madam, what he told was he used to cook food like in
The
the
shipper?
Yes,
The
sir.
shipper?
Yes,
In the ship, they'll cook their own food. Huh?
Is he allowed to cook his own food, or they have to take food from the general mess? No, that's the usual rule in the ship. No, individual cooking is generally not allowed. No.
In the sense, from the mess, cooked food was being eaten from the like.
Now, how often has they've taken canned food? How was it prepared? What's the importance of this?
Ma'am, infectious diarrhea, it can be a.
1 minute. What's the relevance of canned food and diarrhea? What is Bacillus cereus?
Yeah, but Bacillus cereus, a preformed toxin may be there in the canned food.
What history did you ask?
Ma'am, your last statement was not audible. Can you repeat it?
So what questions did you ask the patient?
Madam, I asked about the kind of the food he used to consume. Whether he used
to tell us the details of the food he consumes, no? And how many other members in the ship got any infection? Was he the only person who got the infection? Is it important?
Yes, madam.
Types of infections that can spread across the community, the blood and mucus diarrhea.
Yes, madam. What he said was he did not consume.
6 months on, 6 months off. They'll all be in the ship traveling from one country to the other. And other important thing is you have about half a dozen questions on no history. Can you explain each of these no history that you mentioned, starting from number 1? Excess with thirst.
I also wanted to highlight on that. You can start on this.
Each statement from above below, just tell us why you asked all those questions. No history of excessive thirst, giddiness, reduced urine output, altered mentation. What was in your mind when you asked so many adjectives?
Madam, what I tried to figure out was whether he had
what was in your mind, that first statement?
To rule out any dehydration secondary to
dehydration. With bloody diarrhea, you get dehydration, right?
Okay. Now, at MBBS level, Dr. Ayisha, this may be acceptable. But at DNB or DM level, we will question you because already you are committed to the statement in your previous leg that it is small volume stools. Understand? Yes. You already committed to that it is small volume. So the entire loss of water in the form of diarrhea will be limited. So we generally won't expect such patients to go into dehydration or renal failure or anything, or severe electrolyte imbalance, unless it's a florid severe colitis, which obviously then you would be mentioning that patient has got 10, 20 or 15 times, 50 times loose motion and etc. etc. So that history was not forthcoming. So in the absence of voluminous diarrhea, if you mention all these things, this will become probably unwanted negatives, which will only bring in lot of other questions and take away your valuable time. Okay. So all
The
negatives
third
should be
third
absolutely
statement.
relevant to the case.
No history of swelling of leg, altered taste, pigmentation of skin, reduced vision, bone pain, bleeding. What was all these so many things altogether? Is which disease that you're considering? Swelling of leg, altered taste, pigmentation, reduced vision, bone pain, and bleeding diathesis. What was in your mind?
Madam, that
All
is
these together. All these together you're considering one
malabsorption.
malabsorption.
Okay.
In this patient.
Again, Dr. Ayisha, these are symptoms of nutritional deficiency, micro and macronutrient deficiency, which generally you expect in a small bowel diarrhea with malabsorption. No, here it is a straightforward large bowel diarrhea, no?
Yes.
Okay, it looks like that. So bringing in such things again become little, no, they will unnecessarily question you, know?
Yes.
Because it's a learning session, we tell you, okay, probably those sort of things should be avoided. So again, I want to stress the negative should be relevant to the case, not just random negatives. Okay, that's a lesson for today. Negative should be relevant to the case, because at MBBS level, they will say everything. But at your level, you are already a physician, consultant, and you are trying to get another higher degree. Okay, so at your level, we will expect you to talk like a consultant. Okay, that is we expect from you. Okay, and like a consultant who will discuss or thrash out the differential diagnosis. Okay, not at MBBS level. Okay, that's the difference.
Did you ask for history of abdominal pain?
Yes, ma'am, madam.
What type of abdominal pain?
Can
What
you
was
show
in
the
your
previous
mind?
slide? It is there.
Why did you, what was in your mind when you asked this? What this history? No history of relief of symptoms with fasting. What is fasting to do with bloody diarrhea?
Yes,
Okay,
madam.
again the same problem. You are
Osmotic
considering
pain.
secretory diarrhea, no? So,
Yes.
or osmotic diarrhea, which probably you are mentioning osmotic diarrhea or secretory, to differentiate that sort of thing, which does not come here at all. Okay.
Now, we hold on to the history. History of fatigue, loss of appetite, no history of loss of weight or constipation. Now, can you just see two things are happening? Loss of appetite, no history of loss of weight or constipation. Now, why did you ask for that what is constipation?
Madam, to know whether he had intermittent episodes of diarrhea with constipation.
That the patient will tell that, yeah, I have altered bowel movements, no? Because your previous statement says incomplete evacuation. Is that a feature of constipation?
No, ma'am.
The whole idea is when you bring up this particular history, just focus your attention. It is a problem in the rectum. That's all. So you have to just focus your attention to that and keep on asking history to give some DD referral to the rectum or the proctosigmoiditis or whatever it is. Well, there are too many no histories. Any blood transfusions?
No, madam, there was no history of blood
That I
transfusion.
think she means.
Times did he pass motion at night?
Nocturnal episodes I've asked, ma'am. He did not have.
You mentioned it
Yes,
in your history. I can't see it.
There is some noise. Let me find out where it's coming from. Okay, so ma'am has pointed out that this is a very important question which ma'am has just asked. Nocturnal is because people with organic disease, obviously this is blood in the stool, so it has to be organic. But when so many times he passes motion during daytime, when there's so much of colonic or rectal inflammation, we expect that some nocturnal symptoms should be there. Because it's a little strange that he does not have any loose motion in between, which wakes him up in between sleep. So that's a point which requires clarification. And I think fatigue, loss of that bringing in constipation in between in a patient with an acute diarrheal disease probably a little difficult to accept. The other thing is history of flatulence and borborygmi also in this situation will be difficult. Symptoms on fasting, that also is a problem. Next slide. And all the other negatives which already we have commented upon. Okay.
And the drug history, what were the specific drugs that you asked? Previous slide.
Madam, prior to the onset of the illness, whether he had any consumption of antibiotics?
What percentage of patients present with who take antibiotic present with blood and bloody diarrhea? What are the types of diarrhea you get with antibiotic? What's it called? What is the type of diarrhea that you get?
Others also can answer. Muthu and
Sir,
You get
Pseudomonas colitis.
and what percentage of patients with taking antibiotics will have bloody diarrhea? Because you said no significant drug history. What drugs? The session is mainly so that you get focused onto your history taking.
No, ma'am.
I mean, basically that's
okay,
what we do.
Muthu and other
As you
which drugs?
keep
Which
noting,
drugs?
and then
So most of the antibiotics causes watery diarrhea, sir, because of second Clostridium difficile infection.
Okay, it's a watery diarrhea. Okay,
Yes,
agree.
sir. If in case newer immune checkpoint inhibitor can cause bloody diarrhea, sir.
Then any other drugs can produce acute colitis like picture?
Mycophenolate mofetil, sir.
Okay. Then some NSAIDs, as
NSAIDs.
we discussed earlier, like diclofenac also can produce enterocolitis picture.
MMF and all cause diarrhea only immunosuppressed. They can present diarrhea, not with bloody. There's no bloody diarrhea. Immune
Okay.
checkpoint inhibitors accepted. Yeah.
Okay, sir.
Okay, so yeah, one of you can summarize. Muthukrishanan can
Just
summarize.
just one
Okay.
second. The radiation was the other history that you've asked. In which situation, what radiation are we referring to causing bloody diarrhea?
Madam, any abdominal radiation in the past which can lead to radiation colitis?
When there's a radiation given to a patient, what type of diarrhea would they get and when would they get the diarrhea? Please read about that, okay? It will not be the presentation. The radiation is patients who have brachytherapy, uterine, or they have some of these local pelvic radiation. It's not an abdominal radiation that causes diarrhea. Please read about that, okay?
Yes.
Okay. Can we proceed, ma'am?
Yeah, please, yeah.
Muthukrishanan, please
Yes, sir.
summarize and tell us the possible differential diagnosis.
Yes, sir. Middle-aged male without known comorbidities, presented with large bowel type of diarrhea, predominantly rectosigmoid involvement, with a significant, without recent travel history, without any, with lower abdomen pain, which was relieved after defecation, without any loss of weight or loss of appetite, with the ECOG performance status probably 0.
Okay. Therefore,
My syndromic diagnosis was bloody diarrhea for evaluation. Possible differential diagnosis could be ulcerative colitis and amoebic, persistent amoebic colitis.
Doctor, please classify, classify.
Yes.
Otherwise, we'll go around all the diseases. Classify and then one by one in order of priority. Dr. Sunil, please interact. I keep interfering.
No, I'm learning from you, ma'am.
Okay. No, please. I have a tendency to keep talking, so please interact.
Yeah.
First, probably ulcerative colitis, ma'am. Second, infection in that amoebic colitis, and then persistent bacterial infections such as Yersinia enterocolitis, invasive entero aggressive E. coli, and Crohn's colitis.
What coli?
Crohn's colitis.
Crohn's colitis. Crohn's colitis.
so if you are asked to bet on a diagnosis, what will be your diagnosis?
Sir?
If you ask you to just say one diagnosis.
Ulcerative colitis.
Ulcerative colitis, acute presentation.
Yes, sir.
Your
So it is
first
acute in onset.
presentation in this patient should be an infective colitis. Patient is traveling. Patient is a person who is moving from one place to the other. Your DD will not be inflammatory bowel disease as a first DD. It is proctosigmoiditis, and your DD just classified as infection. It's a DD, infection, inflammation,
Okay.
vascular, neoplastic, miscellaneous. These are the ways you classify. Infection again classified as bacterial, viral, protozoal, and others. That's how you
Okay.
classify. So have examples for each of these.
Okay, ma'am.
You understand? It is too short a history. It's just 4 weeks history, and he's been traveling.
Yes.
And therefore, and it is only for 2 weeks now. So we have to just try to figure out inflammatory bowel disease will come down, 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 down the list. It will not be the first diagnosis.
Okay, ma'am.
In that order, now reorder your diagnosis and tell us.
And in infective colitis, bacterial cause, I would Yersinia enterocolitis and Campylobacter.
What percentage of patients you have seen in your 3 years or 2 years? How often? I've yet to see an Yersinia enterocolitis. I've not seen even one. I don't know whether others have seen. I've not seen it.
We also always discuss about Yersinia. I am yet to see a Pakka Yersinia enterocolitis.
Yeah, maybe it's a Western disease. I do not know. Dr. Sunil, you've seen?
You have been abroad, Dr. Sunil. Have you seen?
No, I have not seen much of chronic diarrhea, which presents over there are more of metabolic, pancreatic, and they're not related to infections. Very seldom we see infective diarrhea in the place which I was practicing.
So don't bring in
Okay,
Yersinia.
Muthu, again,
Campylobacter.
you begin. Okay, what will be the, suppose he has been traveling to different places, no?
Yes, sir.
So he is vulnerable to infections.
Yes,
So what are the common infections which are seen in the community? At least to say about India, we do not know West Indies, we do not know the exact statistics, but the organism all must be fairly same, producing acute infectious diarrhea, acute colitis. It is fairly same type of organisms, no?
Yes, sir.
What
In
is most
India,
common cause of acute colitis of bacterial origin in our country?
amoebic, sir.
Bacterial
Amoebic,
origin,
bacterial.
the usual ones. Then right, sir. Is it Shigella dysentery?
Oh, okay. Yes, sir.
Like that. So which are the common bacteria which produce acute diarrheal disease with a colitis component? Most of them may have a mild form of enterocolitis, but as there are ulcers, not much of ulcer we don't see. But in situation where there is significant mucosal ulceration, we find blood and mucus. Okay. So one is Shigella. Then E. coli.
Okay. Okay.
Different types of E. coli.
Entero-aggressive, entero-invasive,
Enteropathogenic, enterotoxic, enteroaggressive, enteroadhesive. So many things are there. Okay.
Yes,
Then Salmonella is
Especially
notorious to
if a
produce
person
acute
is eating,
diarrhea due
if
to
a
food poisoning and other things. Okay.
Yes,
Then
canned food, if they are taking, what kind of organisms can get into you by canned foods?
canned foods.
We just discussed now.
Any others? Dr. Ayisha and Dr.
Sir,
Clostridium
preform colitis,
toxins, sir.
Bacillus cereus,
Yeah.
then Clostridium botulinum.
Yeah, Clostridium. Bacillus cereus.
Staphylococcus.
Yes, possible. Yes. Okay. Then
And if we
protozoal. Agreed.
Yeah.
Dr. Sunil, continue, please.
No, when you start eating seafood and raw barbecued rare meats, what bacteria gets into you? It's something which commonly affects you when you eat raw meat, because these people eat a lot of steaks, and then you get the medium rare meat consumption. So this can happen, especially to seafarers. But some amount of fever might be there along with diarrhea, and it's often chronic. What you have not mentioned that bacteria. Aisha,
Okay, no answers forthcoming.
how does salmonellosis present?
Bloody diarrhea, sir. Chronic
Fever.
with fever.
Yeah, it may have fever, but the patients sometimes have this chronic diarrhea because they consume salmonellosis is pretty common, especially even in the West.
Pretty common.
It's very common.
We attach to salmonella to typhoid only, but actually it is more important in producing diarrheal disease, especially acute diarrheal disease. Yeah. Okay, then protozoal.
Amoebiasis, sir.
Amoebiasis. Okay. Then
How
any
does-
other protozoa for theoretical concern, I will, because it came from.
How does Balantidium coli present?
Yeah. Any other protozoa? Balantidium coli. Okay, because it has been to different countries, probably you may have to think of exotic organisms as well. Okay.
Yeah.
Can any other parasites produce bloody diarrhea?
Trichura, sir.
Okay. Which is he having the usual risk factor for trichura with blood and mucus in the stools? Which type of patient you have such sort of symptomatology?
Sir, usually seen in infants, sir.
Usually seen in children. Yes.
And those who having immunodeficiency.
Not much immunodeficiency, but probably they are malnourished to a great extent that they are extremely vulnerable. Dr. Sunil Mathai must be remembering his study. No.
Yeah.
He actually did a study long back on extensive trichura. That was the ISG presentation, I think.
What are the types of schistosomiasis and which can present with bloody diarrhea? What are the types of schistosomiasis? They're all these travelers, no? They're all vulnerable to all these infections. Egypt.
Schistosomiasis, Mansoni.
Okay.
No,
Schistosomia japonicum.
Which of them? We know all the
Japonicum.
Japonicum. Mansoni.
And which is the third one?
What are the three? I remember
Hematobium.
Okay.
The president is
Hematobium.
hematuria. I remember in CMC fellow, there was one Egyptian fellow who had come with bloody diarrhea. I don't know what made me think. I just took a biopsy and schistosomia lava were present. So I still remember that, recall that case. Okay, so all because
I also remember Rama telling a person was worked for many years in Middle East and returned, and then there was actually a case of schistosoma. So many of the people from India, especially South India, work in Middle East or other countries for a long period, and probably they get infected. And from this Gulf country, they go to Arab countries like and other African countries also, where schistosomiasis is much more common. So people who travel for work, etc., are more vulnerable.
And vice versa. The Northeast, I mean, all these Middle East people coming to India, no? That's the other group. Vice versa.
Yeah, when they come for treatment from Middle East, Arab people are coming to India for treatment part also. So we must be aware of the possible diseases which are there in their country. Okay.
In this history, there is one glaring factor that for the first 2 weeks it was just diarrhea, and the blood started appearing only after 2 weeks. So, what organism would you possibly think about? Because the first instance it was 2 weeks of watery diarrhea. There was no blood, and blood came later.
Salmonella, sir.
How do you explain that the symptomatology?
So initially watery diarrhea, then followed because of the ulcers.
You mean to say after 2 weeks the ulcers are bleeding and that is why? But this is not a case of classic Salmonella typhi. It is usually due to other organisms, Typhimurium or Paratyphi or other type of organism. There are so many other Salmonella organism other than typhoid organism which is capable of producing diarrhea. Can it be Campylobacter? Campylobacter diarrhea is also supposed to linger a little longer if not treated. Okay.
Is it possible that we are dealing with carcinoma rectum? Neoplastic? CA.
Young age, without family history, with no warning signs, or no weight loss.
Oh, they can present for the first time as bloody diarrhea. What is the, how will you differentiate? How will you differentiate? I say it is neoplastic carcinoma rectum. How will you differentiate this from IBD? You know, your other DD was IBD.
He has
Infective,
got rectal,
infective,
he has got
yeah.
tenesmus, he has got incomplete evacuation, he has got fresh blood, he has got increased
Infective,
frequency. What else you
yeah.
want?
Infective, inflammatory, neoplastic. Differentiate all these three. Yes, Dr. Zhumu. That's important. No, suddenly you find there's a growth below.
Madam, patient had bloody diarrhea with lower abdominal pain, and there is no history of fever. Inflammatory is a possibility. Rectal urgency, tenesmus, and all is there.
The onset. Tell about the onset. In acute diarrheal disease, the onset will be fairly acute, not the insidious type of problem which this patient with neoplasm not. No. Okay, here it is an acute. He was all right until today morning, and then he developed a symptom that will occur. Okay, this is a fairly acute onset of symptoms. Okay, then suppose it is ulcerative colitis, as mentioned as one of the differential diagnoses. Can you differentiate? Muthukrishanan.
Yes, sir. Actually, this case, first initial presentation of loose stool, then bloody stools. In case of carcinoma, the initial presentation itself, some altered brown color stools.
No. My question is that suppose it is ulcerative colitis, how will you differentiate it from an acute colitis versus a neoplasm? Do you have enough points in the history to differentiate from history?
No, sir.
There are no extraintestinal manifestations, sir.
We need not. The first presentation, probably we may not have any of these things. Extraintestinal, generally, in the case of ulcerative colitis, by and large, most of the time we have not seen this antedating. Sometimes it may happen, but it is not usual. So if it is inflammatory bowel disease, it's a very, very rare form of acute presentation of ulcerative colitis. It's an extremely rare presentation, less than 10% of the people, and it presents exactly like acute colitis. It will be very difficult to differentiate it from clinically. So onset will be acute, okay, and everything will be like an acute. But in the case of acute infectious diarrhea, if fever is present, that will be a point in favor. Okay, because very often in an infective diarrhea, that may be associated fever in the initial few days. And more prostration, more crampy pain, all those things are more in favor of, because severe pain in the initial presentation and ulcerative colitis also is not that very common. But in acute diarrheal disease, they can have very severe pain on day one itself because of the effect of toxins and other things. So some points are there, but in a severe ulcerative colitis acute presentation, we may not be able to differentiate it completely clinically. We may have to investigate and try to find out whether there's an infection.
What was the frequency during the day and night? What was the frequency? Ayisha?
Frequency in the day was around 4 to 5 times, ma'am. And
that's all. 4 to 5 times is not IBD, okay? And that too acute. It'll be acute.
Yeah, that's a very good point, ma'am. That's a very good point.
4 to 5 can just be carcinoma. It can just be some malignant pathology. 4 to 5 is not IBD.
Because severe ulcerative colitis, they'll be literally in the toilet. Every now and then they have to run to the toilet because of intense inflammation and increased frequency,
they'll be toxic, they'll be sick, they'll have to be airborne. They will not be just moving from one place to the other 3 to 4 times a day. So your DD has to be, one is infective, okay, but even infective shigellosis and all, they'll be more toxic, they'll be having fever, they'll have some joint pain, they'll have this blood and mucus diarrhea, they'll be very sick. So please keep a wide option available. Just keep all the possibilities so that you don't miss anything. So that you don't miss any of these. Sometimes, as Dr. Sunil and all were talking, it can just be some mesenteric vasculitis or something presenting with diarrhea, with this just bloody diarrhea. So just keep a wide option, so that this is something unusual because he's traveling, and so infective will come little down. Inflammatory ulcerative colitis and all these acute onset, they'll be very severe, like they'll pass nighttime, they will just get up to keep on passing motion. Moment motion comes to the rectum, they'll get to the toilet. Comes to the rectum, it goes to toilet. Okay?
Yes, ma'am.
Okay. Can we just
Okay,
move on?
we'll, Dr. Ayisha.
Dr. Sunil, please give your comments on the history taking so that they get a summary of what is to be discussed, in the history taking.
I think her history taking was extensive, and possibly she needs some more experience in avoiding certain history or highlighting certain history. But she has extensively covered the history. That's a good point in favor of taking a history. She has covered the acute diarrhea and the chronic diarrhea, and possibly all the manifestations of diarrhea she has put into that slide, which possibly may not be required. But then when you put the syndromic diagnosis, the inflammatory came before the infective. So I'm not for inflammatory diarrhea before the infective. I totally agree with you, ma'am, that infective diarrhea has to come first. And then
The other thing was just one shot in the history. Look at that in the summary. There's a very umbilical colicky abdominal pain. Now this never came up in the history at all. Suddenly it looks like a Crohn's now. This never came up, periumbilical colicky abdominal pain. There was no description of pain, if I remember right. It was all related to passage of.
Actually, in the history, she mentioned lower abdomen pains.
It was mentioned along with the diarrhea.
Lower abdomen pain, he was
pain
mentioning.
Periumbilical colicky abdominal pain becomes small bowel then.
The procedure by lower, here it actually lower abdominal pain.
Lower abdominal cramps and tenesmus.
In the summary, it is periumbilical. So such a difference should not occur.
Ayisha, can you just clarify periumbilical or lower abdominal, please?
It was lower, ma'am, lower abdominal pain.
Then why was the periumbilical is Crohn's? Then it becomes totally Crohn's. Small intestinal pain, this thing inflammatory, it is inflammatory.
Okay. So each of your word will be analyzed critically. Some of the examiners actually try to analyze each and every sentence which you tell and try to find out whether you are telling with a purpose or you are just involuntary, just completing so many sentences in a routine fashion. Okay, so they want to know whether you are actually thinking of the case and intelligently making an output. That's what they are trying to assess. Okay, so you have made a good presentation, but it requires a lot of editing. I think physical examination, just we have already covered 45 minutes, so we want to finish fast.
On general physical examination, he was conscious, oriented, and cooperative. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or peripheral edema. His BP in supine position was 120 by 80 millimeters of mercury in right upper limb. Pulse rate was 78 per minute with a respiratory rate of 17 per minute. He was afebrile. Thyroid examination was normal. Skin, there was no hyperpigmentation, rashes, or any petechiae.
Just hold on. Let's go back.
Hold on.
Now tell, cyanosis, clubbing, it's like Jack and Jill went up the hill, no? Cyanosis, clubbing, lymphadenopathy, edema, no? Can you just tell, why did you ask for cyanosis and clubbing in this patient? Look for it. Did you spend time looking for cyanosis? What type of cyanosis did you look for? You spent time, few seconds for looking cyanosis.
Cyanosis, ma'am, in relation to diarrhea, no, ma'am. I was just trying to complete as a part of general physical examination.
Oh, don't do it. Clubbing? You cannot complete from head to toe. Then you still talk of skin luster, then talk of the
clubbing again in terms of small bowel diarrhea, ma'am, not in relation to the large bowel diarrhea. In terms of small bowel diarrhea, maybe conditions like any small bowel lymphoma or IPSID can have clubbing.
Small bowel lymphoma will not cause clubbing. Which are the conditions which cause clubbing?
Whipple's disease, ma'am.
How many Whipple's disease have you seen in your life, Ayisha? Not seen. I've not seen in 30 years of practice. I've not seen anything. I don't know how many people have seen people's disease. Hmm. What can cause clubbing? It's a basic question.
IPSID can cause immunoproliferative disease of small intestinal diseases.
So be
Okay,
very
small
careful.
intestinal disease.
What
We are
I
already
want-
considering
What we
large
want to
intestine.
highlight is just be focused on the patient. What we need in this patient is pallor. We need to know whether there's partial hypertension. We need to know what is the degree of anemia. Does he have partial hypertension? 120 by 80 and standing 110 by 80. Does he have partial hypertension? What is your inference?
No, madam, he does not have.
When do you say patient has got partial hypertension?
Ma'am, a systolic drop of more than 20 millimeters of mercury after 3 minutes of changing the posture.
So there's no significance. So despite so much of blood loss and all, there's no pallor. Icterus in this patient, significance?
Icterus, again, not in this case, ma'am, but if you're suspecting any small bowel disease,
See, I'll tell you something. If the person has icterus, no, then the chief complaints itself will have jaundice, okay? The jaundice will come as a chief complaint, okay? So supposing this case comes to you in the OP, no, as you quickly see, you'll see his body build. You'll just check his BMI. You'll just see whether there's gross anemia. You look for the pulse rate. Is it matching with the pallor? You look for a postural hypertension. And you look for any cutaneous markers of internal malignancy, cutaneous markers of IBD. Can it be polyposis? He's a young person. Can it be FAP? Can this patient be a case of familial adenomatous polyposis? Can it be juvenile polyposis coli? He's a young person with bloody diarrhea. So in your general examination, just focus on the body build, the anemia, then focus, we are waiting for that, no? Cutaneous markers of polyposis, cutaneous markers of IBD, cutaneous markers of internal malignancy. 3 things that we are really looking forward to this patient because the frequency was 3 to 4 per day.
Yes, ma'am.
And it is recent onset. Have you understood?
Yes.
Yeah, I would really not waste my time looking for icterus or cyanosis or clubbing. As you see the case, as the case comes to you, your first target will be, okay, this is the history. So I will look for this and I'll keep looking for cutaneous markers. Can you just tell what are the cutaneous markers you will look for in this patient? You mentioned hyperpigmentation, rashes and fatigue. Can you just highlight why did you mention that rashes and fatigue? What was in your mind when you looked for rashes and fatigue?
Ma'am, fatigue in case of malabsorption, in case there is a vitamin K deficiency.
How often have you seen, doctor? Diarrhea, I've yet to see fatigue. I've yet to pick up fatigue.
Mostly these are cut and paste, ma'am. I think these people, what they do is they just cut and paste a lot of routine things which are as a part of a presentation. But here, clinical application has not been done as to her slide. It's obvious. When particular.
Okay, I think to both of the faculties, this is her first presentation, and they are second years, and they are not used to present in.
BT, I
So
want to
probably lesser experience is there. So we will.
BT, they are post MD. BT, they're post MD. Okay, we are talking only
Agreed,
at
agreed.
MD level. We are not talking at all of DM level at all. We're talking only of MD, and I think they should understand. No, they should understand. See, I'll just tell you, when I see this case in the OP, well, I spent I do not know whether you saw the case in the outpatient clinic, but would you specifically look for rashes? That's what we want to convey. Would you look for a petechiae? Would you look for a rash in the outpatient clinic? How many of us, Dr. VT, Dr. Sunil, and all, have you really looked for this in this context? You understand? In Henoch-Schönlein, yes. In Henoch-Schönlein, you look for petechiae because then the history will be there, right? So always see what is the history, what is the presentation, and then focus your attention. Okay, this is the history taking, then this is what I must focus this thing into. And general examination, look for some arthralgia. So just keep focusing on that. Very important, I'm telling you, you're all lucky that as second years you're presenting. But actually what we're talking is only at MBBS and MD level. We're not talking anything as far as DM is concerned. We have not touched DM at all. This only your training here is only for history taking and physical examination. Okay. So don't take anything to your this thing, but I'm very practical about it, that when you see a case in the OP, what is it that you're looking for? That's all that we're highlighting. Okay.
Okay, actually, that's very important, the examination as well. Okay, because there is limited time. Unlike in DM where you have 1 hour, I think they have only 30 minutes, no? 30 minutes to present a short case like that, but the question
Only
should be
30.
like a long case. That's
Only 30.
unfortunate thing about DRNB. So within that short period, you have to take history. Once you get the gist of the history, you have to start examining and examine relevant general examination points, and the negative should be highly relevant to the case. As in the history also we told, the negatives in the history mentioned should be relevant to the case. The negatives in the physical examination also relevant to the case, because it should be relevant to the DD which you are already mentioning. Otherwise, don't mention. Okay. Is that okay? Just we'll proceed. Anything else on physical examination? We'll leave out skin fold thickness, MAC, etc. That's all part of malnutrition. Any physical examination findings?
No. One of them has to highlight on the cutaneous markers. Okay, let us discuss. Tell us few cutaneous or extraintestinal manifestations.
Tell us the cutaneous markers of malignancy of the intestine.
IBD, neoplasia, and this thing.
Okay, we'll make them present. Okay, now Muthu, can you say the cutaneous manifestation associated with the GA neoplasm intestinal?
Yes, sir. And for IBD, bioderma gangrenosum.
No, I am asking you neoplasm.
Neoplasm,
sir. My question.
Okay, sir.
Small intestinal tumors, large intestinal tumors, polyps. Think of that way.
What are the features of Peutz-Jeghers, Cronkite Canada, blue rubber?
Sir, for Peutz-Jeghers, oral, perioral hyperpigmentation, sir.
Okay.
For neurofibromatosis is cutaneous neurofibroma.
No, doctor, I tell you, first keep all the syndromes in mind. Only then you'll know, no?
Yes, sir.
So what are the syndromes?
Peutz-Jeghers, what do you look for? For Gardner syndrome, what do you look for?
Cronkite Canada, what will you look for? Gardner's, Cronkite Canada. That's how, only then when you know the syndrome, will you be able to see, no? Otherwise, you're likely to miss the findings.
Okay.
So
for IBD?
All this. Please read all this, yeah.
Yes. For IBD, bioderma gangrenosum.
Okay.
And erythema nodosum.
Okay.
And then oral pyomyositis vegetans and oral aphthous ulcer.
Aphthous ulcer. And in the eye?
Eye scleritis and episcleritis.
Sometimes there may be cutaneous Crohn's as well. Okay. Fine. Okay, I think in the physical examination of the abdomen, there was nothing abnormal, no? Dr. Ayisha, is there anything positive?
No, sir, it was normal.
Okay,
within normal limits.
And okay, so we will close the case here. Was it investigated? Was it investigated in detail?
Rectal examination is normal, no? Rectal?
Yes, madam. During the time of examination, it was normal. There was yellow stained stools. Perineal region was normal, and anal sphincter tone also was normal, ma'am.
In this particular patient, what are the things that you look for? It may be really painful, no? So how will the mucosa appear? Boggy, okay? You can have a boggy mucosa. And you may find occasionally some pseudopolyps.
Your peer was showing normal yellow-stained stools, but the patient was saying that it was a bloody stool.
Yes, sir.
How do you explain that?
Maybe when I was examining, that was normal. There was.
Could it be an anal verge bleed, especially when a patient has got multiple episodes of evacuation? Sometimes anal verge bleeds, the sources can be an anal verge bleed like a hemorrhoid or a fissure. Do you think that there was an anal verge bleed because the stools were yellow?
Possible, sir, but in PR examination.
What will be the history then?
Painful defecation would be there, sir.
Depending upon the condition. If it is anal fissure, only painful. Suppose it is hemorrhoidal bleed.
There will be a gush of blood prior to the defecation. Like it won't be intermixed. Prior to that, the blood
So usually in a colitis, it will be stools, loose stools with the blood and mucus mixed. That's the usual story, no? Not isolated bleeding here, either in the beginning or end. In
When
spurts.
did the patient last have a bleed? When did the patient last have a bleed?
Is he
While he
continuing to have bleed?
While he was, during hospital stay, he had episodes, madam.
So when the motion is yellow in color, what's your inference? That's a very pertinent question by Dr. Sunil.
It could be
Okay, ma'am. It's 9 o'clock. We have to discuss the symptomatology. Dr. Ayisha, in one sentence, can you tell us what was the final diagnosis you found out from the hospital?
sir, it was inflammatory bowel disease, sir, ulcerative colitis.
That was the biopsy report. What was the
Biopsy.
scopy finding?
Scopy finding, there was extensive superficial ulcerations with blood and mucopus involving right from the cecum till the anal region, so till the rectum. So it was a picture of extensive colitis.
So as per the endoscopy as well as the biopsy, it is an acute severe ulcerative colitis.
It may still be infective colitis.
How will you differentiate it from acute colitis?
Tell us histology.
Suppose I say it is acute colitis only. Because the short history.
Sir, the lymphoplasmacyte infiltration with basal plasmacytosis is more specific for
okay. More specific for what about cryptitis and cryptapsis?
They can be found in.
It can be found in both. Cryptitis and cryptapsis can be seen in acute infective colitis as well. Okay. Then usually neutrophilic infiltration can be there, but more in an acute colitis. Some degree of round cells will be there, but if the basal plasmacytosis is there and lymphoplasmatic infiltration, it is more in favor. Some degree of crypt atrophy is seen here, crypt distortion and branching, generally suggesting some degree of destruction and regeneration, which is more in favor of a chronic process. So 2 points are there in this histology, which will suggest probably IBD rather than acute colitis. Okay, so you should also learn to differentiate the histopathological difference between acute ulcerative colitis versus acute colitis. This is a standard question which is asked in all examination. Okay, I think it's time that we proceed to the discussion. Dr. Ayisha, please start your presentation of approach to diarrhea.
I hope the discussion is on bloody diarrhea, not watery diarrhea, okay?
Yeah, this is the case of actually acute bloody diarrhea, not the usual type of diarrhea. Okay. Good.
I'll proceed, sir.
The slides are not there?
Yes, the connection was lost.
Okay, start.
Diarrhea, by definition, is increase in the stool frequency or decrease in the stool consistency. A frequency of more than 3 times a day is considered abnormal, and consistency is basically the ratio of the fecal water to the water holding capacity of a fecal insoluble matter, which are composed basically of bacterial mass and dietary fiber. So in practice, a Bristol stool chart helps us to assess the stool consistency, by which the types beyond 5, 6, and 7 are considered to be diarrhea. And stool weight is considered to be a surrogate marker of diarrhea. Weight or volume of the stool usually is used to be measured over a 24 to 72 hour period. A stool weight of more than 200 gram is an objective definition of diarrhea in a person consuming a Western diet, but in a in high fiber diet, including us Indians, the stool output can be as great as 400 grams per day. Then just a few words about pseudodiarrhea. Pseudodiarrhea is basically the patients presenting with the complaints of diarrhea. In 20% of the patients, they have a normal stool weight with symptomatology of diarrhea. So basically, they have a passage of small volumes loose stools or more frequent passage of the formed stool. Then we have conditions like fecal incontinence, which also can be falsely attributed as diarrhea in clinical practice. This is basically the involuntary leakage of the fecal matter through anus or inability to control the discharge of bowel contents. Now, this can be passive incontinence where the patient is not aware of the passage of the feces and flatus, usually seen in the like neuromuscular disorders of the rectal area. The patient can have an overflow incontinence, especially in bedridden elderly patients who have a constipation for a long time. They can go into a fecal incontinence and diarrhea. And there can be urge incontinence where the patient is unable to hold the stools till they reach the toilet. And there can be factitious diarrhea also, which is caused by the surreptitious ingestion of laxatives. Now, talking about duration of diarrhea, according to the duration of diarrhea, we can divide it as acute diarrhea when the onset is less than 2 weeks, and it is said to be chronic when it is more than 4 weeks. But any acute diarrhea that persists for more than 2 weeks, it may be termed as a persistent diarrhea. Now, a few words about organic and functional diarrhea. Organic diarrhea, the onset is usually abrupt, whereas in functional diarrhea, it can be insidious. Duration, organic diarrhea usually short duration, and functional diarrhea, they may give a long history. And constitutional symptoms will be less marked in functional diarrhea. And there will be no alarming symptoms like loss of weight or loss of appetite. And there won't be any episodes of nocturnal diarrhea in functional diarrheas. And gastrocolic reflexes will be maintained in case of organic diarrhea, but that may be aggravated, increased in case of functional diarrhea. And there will be a component of anxiety symptoms in functional diarrhea compared to organic diarrhea.
One of the things when you differentiate all these by charts is sometimes this overlap you should not miss. For example, in organic diarrhea, like ulcerative colitis, has also been classified as psychosomatic. So anxiety symptoms are known to aggravate the situation. So we should always keep in mind when you learn these as different, when you differentiate these, there is an overlap which you will overlap. So just to warn you that don't go strictly by the terms of these differentiations. Yeah.
Then history-wise or examination to distinct between the small bowel and large bowel diarrhea. The small bowel diarrhea will be usually of large volume diarrhea. There may be excessive flatulence. There can be history of steatory and malabsorption, and blood and pus in stool is more in favor of large bowel diarrhea. As already told, abdominal pain will be more periumbilical and central in case of small bowel diarrhea, whereas it is usually in the lower abdomen for large bowel diarrhea, which improves with defecation. Rectal symptoms like tenesmus and urgency are present in large bowel diarrhea and will be absent in small bowel diarrhea. Now, why this difference comes, this large and small bowel diarrhea. Now, in a person, normal rectosigmoid colon functions as a storage reservoir. So when this reservoir capacity, if there is a left colon disorder, this reservoir capacity of the left colon is lost, and that results in frequent small volume painful bowel movements. Whereas in case of if the left bowel is intact and the pathology is proximal to that, then usually as the reservoir function of the colon is intact, the bowel movements are less frequent and they'll be painless with large volume stools. Come to acute diarrhea, as I've told, it is less than 4 weeks duration. The cause is usually infectious. Usually it goes up to 1 week. More than 7 days, the suspicion should be of a protozoal etiology like a giardiasis or cryptosporidiasis. Some infectious agents like Yersinia or Aeromonas can cause persistent diarrhea in immunocompetent individuals. Now, other than that, food allergies, some of the medications and toxins can present as acute diarrhea, and that can be also an initial presentation of a chronic diarrhea. Now, the infectious agents causing diarrhea among bacteria, Aeromonas, Campylobacter, Clostridioids, E. coli, all ETEC or EIEC or EHEC, Mycobacterium TB can cause, Plasmodium species, Salmonella species, Shigella and Yersinia. Among the virus, we have adeno and CMVS and norovirus and rotavirus.
Which is the most common, can I interrupt you? Which is the most common diarrhea in the world? Common causes of diarrhea in the world, which is the most common cause of diarrhea in the world?
Viral diarrhea, sir.
Which virus?
Adenovirus.
Okay, please continue.
Adults in children.
I wish the focus was on bloody diarrhea, no, for today's discussion, because we've not discussed watery diarrhea and all. Anyway, continue, just finish it.
Okay, continue, please.
So coming to toxin-induced, the infective causes of diarrhea, we have toxin-induced or non-inflammatory and inflammatory diarrhea. In toxin-induced diarrhea, there are infective causes like by preformed toxin and enterotoxins. Preformed toxins usually have a shorter incubation period, like Bacillus cereus or Staphylococcus aureus, where the incubation period is less than 6 hours, and the Clostridium perfringens can go up to 12 to 16 hours. Whereas for enterotoxins like Vibrio cholera or ETEC, incubation period is usually 1 to 2 days. Whereas in Shigella, Salmonella, Enteromoeba histolytica or Campylobacter, it is more common, causes bloody small volume diarrhea with the lower quadrant abdominal pain. The patient will be usually febrile and toxic in this case. Now, common medications and toxins causing diarrhea, we have PPIs, acid-reducing agents, antacids, and drugs like antiarrhythmics, quinidines, many antibiotics and anti-inflammatory agents, antihypertensives, olmesartan among them, and beta blockers, then anti-neoplastic agents, immune checkpoints inhibitors, anti-retroviral agents, predominantly the protease inhibitors, then colchicine, heavy metals, herbal products, a big variety of medications. Then this is a brief flowchart on how we evaluate. Once we take up the history physical examination, the initial assessment should be, the further continuation of the management should be depending on the clinical condition of the patient. If the patient is non-toxic and there is no signs of any dehydration, symptomatic therapy may be given. Or if the patient has symptoms of dehydration, or if the patient does not respond to symptom therapy, he needs admission and IV fluid repletion, and we go for lab evaluation, and in CBC we check for leukocytosis and presence of any underlying what is the status of the infection or inflammation, and his renal function status, electrolyte status, and we may rule out amoebiasis infection by sending an amoeba serology, and we do a stool test to look for ova or parasites, and in case of persistent symptoms, as I told earlier, Giardia antigen may be sent in stool, and in case of antibiotic exposure, if at all there is a history, Clostridium difficile toxin may be checked, and if stool routine is showing fecal WBC, then we will send a stool for culture sensitivity and treat according to the accordingly. And if the diarrhea persists, the next line of investigation would be he would require endoscopic evaluation with biopsy, and then consider the specific therapy according to the diagnosis, or an empirical antibiotic therapy. Chronic diarrhea, history-wise, we should.
Urinal biopsy?
Sir?
Urinal biopsy.
Duodenal biopsy.
Talking of diarrhea, why colonoscopy and not urinal biopsy? What's the role of duodenal biopsy in diarrhea, watery diarrhea? Duodenal aspirate and biopsy.
Some infective etiologies like giardiasis may be more like more.
Which parasite is invasive and which parasite is non-invasive? In your flow chart, there's no mention of the duodenal biopsy. No? Where will the duodenal, just move back, just go back. Where will the duodenal biopsy come in?
Ma'am, in case of persistent diarrhea, in order to rule out the giardiasis condition, like we may consider.
Any other? How will it look for bacterial overgrowth syndrome? SIBO.
SIBO duodenal aspirate culture we will send, ma'am.
Any other? What's the role of breath test? It's not complete, you know, your algorithm. I don't know where it is starting and what's happening. Somewhere something
Probably
is.
we have it in our chronic diarrheal workup, ma'am. We'll wait for the chronic diarrheal workup by algorithm. Let's see.
Okay.
So chronic diarrhea. In the history, we look for duration to differentiate acute versus chronic, and onset, whether it is abrupt or gradually in onset, and the pattern of diarrhea, whether it is continuous or intermittent, and history of epidemiology in case of travelers or any epidemics nearby, and the history of associated diseases like diabetes mellitus or retropositive status or institutionalized patients. Then appearance of the stool, bloody stool or stool with mucopus, and volume of the stool, whether it is large or small volume, presence of nocturnal episodes, so that we can differentiate basically from organic from functional diarrhea, presence of iatrogenic factors like any history of bowel surgeries in the past or any history of recent hospitalizations, then or history of antibiotic exposure. Then consider the history of factitious diarrhea. This is more so in case of patients with eating disorders, and if any behavior abnormality is considered, or in suspicious case of Munchausen syndrome, etc., fictitious diarrhea history may be considered. And in the family history, we focus more on the neoplastic, whether there is any history of the neoplasm in the relatives, any history of inflammatory bowel disease or celiac diseases, systemic diseases like any endocrine disorders like thyroid illness and any collagen vascular disorders in the family, or not in the family, if the person is having, or any neoplasms, any concurrent neoplasms or any immunological disease, or if it's on any medications for immunological disorders. Then presence of fecal incontinence, presence of abdominal pain, and alarming symptoms like weight loss, whether the person's symptoms gets aggravated by any particular diet or stress, and what are the alleviating factors. Then on the physical examination, volume status of the patient, and assessment of nutrient deficiencies, BMI, and various manifestations of vitamin deficiencies. Cutaneous manifestations like urticaria pigmentosa, dermatographism, like any internal celiac disease, or migrating necrotizing erythema, then hyperpigmentation, flushing, or dermatosis herpetiformis, presence of any muscle wasting, edema, thyroid nodule, lymphadenopathies, tremors or lead lag, presence of any right-sided heart murmur or wheezing, presence of any arthritis. In the abdominal examination, we will look for any presence of any distension, tenderness, mass, bowel sounds, hepatomegaly, any abdominal bruit, and in the PR examination, whether the presence of blood, pain, or any anal sphincter weakness. Now, these are the cutaneous and mucosal markers table from Schlesinger, which tells us which are the cutaneous markers which can be a manifestation of the internal malabsorption, mainly in case of a small bowel diarrhea. Then in the general physical examination, we may look for ask for any musculoskeletal features also, which can point us to the specific etiology, like any presence of a bone pain, osteomalacia, or fractures, which can be a manifestation of a protein, calcium, or vitamin D deficiency, tetany, muscle weakness, or paresthesias, which can be malabsorption of vitamin D, calcium, magnesium, and phosphate. Then presence of amenorrhea, impotence, or infertility can be a like protein malabsorption or secondary hypopituitarism anemia. Then anemia, as in case of deficiency of iron, folate, or vitamin B12 deficiency, calorie and anemia by fatigue or weakness, and presence of specific vitamin deficiencies like night blindness, xerophthalmia, or neurological symptoms and ataxia, peripheral neuropathy, or weight loss or hyperphagia in case of nutrient malabsorption. Now, to investigate further, we would go with a baseline blood investigations initially. In the CBC, we look for H-beat for the presence of anemia, and MCV, whether it is an iron loss anemia or a vitamin B12 deficiency anemia, to differentiate. And total count may be increased or decreased. Leukocytosis or leukopenia can be there, especially in case of an immunosuppressive status. So differential count also will help us to determine that, and even eosinophilia, if at all it is there, to consider possibilities like an eosinophilic enteritis. Platelet count, thrombocytosis may be a marker of chronic inflammation, can be there. In the peripheral smear, we check for characterization of anemia and look for any particular clues like acanthocytosis, as in case of a beta lipoproteinemia. Then a renal function test in case of any prolonged diarrhea, whether what is the status of the renal function, the creatinine, whether it has been affected. Then serum electrolytes, sodium, potassium, calcium, and magnesium, all this pointers, especially in a prolonged diarrhea, whether there is electrolyte loss, or it can point out to nutritional status also. In the liver function test, we would look for albumin. Hypoalbuminemia can be seen in inflammatory bowel disease or protein-losing enteropathies, etc. Globulin in case of hypoglobulinemia, or even in a severely malnourished patient. ALP, which could be a feature of, again, vitamin D and calcium deficiencies in case of malabsorptive condition. Then specific nutrient deficiencies may be checked if it is suspected, like iron, folate, or vitamin B12 levels, and HIV status in wherever as indicated. Then we look for stool analysis. In a microscopy, the appearance of the stool, the presence of blood or mucus in the stool. In the microscopy, a leukocyte, especially in an inflammatory diarrhea, leukocytes can be there, and we go for wet smears or after concentration technique, particularly for ova and cyst. Special stains like Sudan or acid-fast stains may be used for coccidian parasites. Occult blood may be checked in order to rule out any ulcerative condition. Then in case of inflammatory diarrhea, fetal calprotectin may be checked, and pH and reducing substance if an osmotic diarrhea is suspected, and fecal fat estimation in case of suspected chronic fatty diarrhea.
Parasites in stool examination.
Yes, ma'am. We check for ova and cyst, ma'am, in the stool examination. And special staining techniques may be used for coccidian.
Will you ask for fresh stool sample? Which parasite will you ask for fresh stool sample?
Fresh stool samples, ma'am. We can. One is Entamoeba histolytica. Fresh stool samples may be required, and in case of giardiasis also, because basically identified by the motility of the organism, madam. So
Where do you do a hanging drop?
in case of a Vibrio cholerae,
When do you do a fecal elastase?
fecal elastase in case of a suspected fatty diarrhea, steatorrhea. We'll go for a fecal elastase. In case of suspected pancreatic insufficiency, exocrine pancreatic insufficiency.
Fecal fat. What are the methods of doing fecal fat?
Sorry, ma'am.
Fecal fat.
Fecal fat is estimated by Sudan staining, sir, where the fat, the globules are examined under the microscope.
How much of stool do you take and how do you do the test? What are the name two or three methods of doing stool fat estimation? What are the various methods of stool fat estimation?
Is Sudan estimation quantitative or qualitative or semi-quantitative? Suppose you want to estimate the real loss of fat through the feces. Do you have a quantitative technique?
Yes,
Any breath test? Please read all that, okay? You can move on.
So by this point, we can differentiate
what happened to the diurnal biopsy, diurnal mucosal biopsy?
Ma'am, in the evaluation of like secretory diarrhea, I'm coming to it.
Is it coming?
Yes, yes, sir.
Okay, we'll wait.
So the diarrhea here, we may classify it as watery diarrhea, inflammatory diarrhea, or fatty diarrhea, depending on our present,
that inflammatory, for easy, for purpose of discussion, put it as bloody diarrhea. Inflammatory is histological, whereas fatty is macroscopic, watery is macroscopic, so inflammatory you switch over as bloody diarrhea. Are you understanding? Inflammatory is histology, right?
Okay.
Just for purpose of discussion, it's easy to classify it as watery, bloody, and fatty.
So in case of a watery diarrhea, to distinguish between osmotic and secretory diarrhea, first regarding the we have a stool osmotic gap, which is basically the stool serum osmolality minus the stool osmolality. We measure the sodium and potassium, and 290 minus 2 times the sodium and potassium value is been checked, which is low in secretory diarrhea because of the loss of the low concentration of the electrolytes in the stool, and it is high, more than 50 milliosmoles in case of osmotic diarrhea. Now, osmotic diarrhea is usually caused by the ingestion of the polyabsorbed cations and anions like magnesium sulfate and phosphate, or polyabsorbed sugars or sugar alcohol. So that basically results from the osmotically active polyabsorbed solutes in the bowel lumen. And it can be also caused by sugars or sugar alcohol because monosaccharides they can usually be absorbed intact across the apical membrane of the intestine, whereas disaccharides are usually not absorbed. So these disaccharides like sucrose or lactose are ingested. If there is absence of disaccharides in the intestinal brush borders, that will preclude the hydrolysis of the disaccharides and its absorption. So that will cause the retaining of these disaccharides will cause the osmotic diarrhea. The most common clinical syndrome of disaccharide deficiency is acquired lactase deficiency, which accounts for lactose intolerance in many adults. Then we have conditions like congenital sucrose and trehalose deficiencies, which are rare and prevent adequate digestion of sucrose and trehalose. And then spectrum of foods that potentially contribute to osmotic diarrhea has been expanded with the recognition of a group of foods containing polyabsorbable fermentable oligosaccharides, that is basically FODMAPs. Now, the features are that the essential characteristic of osmotic diarrhea is that it resolves with fasting or the cessation of ingestion of the offending substance. Now, here electrolyte absorption is not impaired and electrolyte concentration in stool water are usually low. Now, so ultimately, if the fecal osmotic gap, if it is elevated, stool magnesium output and stool ethylene glycol output is checked, and if negative, stool phosphorus or sulfate output may be checked. If the stool pH is less than 6, it is basically carbohydrate malformation. And so we have to go for a diet review or a breath hydrogen test with lactose or measurement of stool reducing substance by Andron reaction. So osmotic diarrhea, basically go for a stool analysis. If the stool analysis is showing a low pH, suspicious of carbohydrate malabsorption, then again dietary review may be done for the said offending substances and breath hydrogen test and a lactase assay. If it is a high magnesium output, then we have to consider other possibilities like inadvertent ingestion of any laxatives. Basically, factitious. In terms of idea, the mechanism is by the inhibition of anions and net inhibition of sodium absorption. So basically, the stimuli for altered electrolyte transport arise from the intestinal lumen, subepithelial space, or systemic circulation, and substantially alter the messenger systems that regulate ion transport pathways. Now, there is a big list of causes of secretory diarrhea. It could be by the infections like enterotoxin, which interact with the receptors and lead to anion secretion. It could be produced by tumors, peptides producing endocrine tumors. There can be genetic causes like congenital chlorhydria or congenital sodium diarrhea, etc. Or exogenous agents also can cause, some drugs and toxins can cause secretory diarrhea. Then in case of decreased absorptive surface, as in case of a celiac disease or resective surgeries, or sometimes even in case of inflammatory bowel disease, there can be secretory diarrhea. Then abnormal motility because of the rapid or slow transit, and reduced intestinal blood flow, as in case of mesenteric ischemia or radiation enteritis, also can result in secretory diarrhea. So basically, we have to exclude the infections. For that, we need to send the bacterial culture, test for pathogens, microscopy for ova and parasite, giardia, cryptosporidium antigens, and special techniques for organisms like cyclospora or coccidia and microsporidia, with or without PCR assay as needed. Then consider in case where structural diseases are considered, like short bowel syndrome or fistulas or mucosal disease or any tumors, we have to go for abdominal imaging in the form of CT or MRI for abdomen pelvis, and accordingly plan for a sigmoidoscopy or colonoscopy with mucosal biopsies. Then again, to rule out a small intestinal bacterial overgrowth, small bowel mucosal biopsy, and even aspirate for quantitative culture, and capsule enteroscopy is also been mentioned as the one of the investigative tools. Then comprehensive metabolic profile, as in when indicated, like TSH, serum cortisol, the diabetic status of the patient, and in case of celiac disease, IgA tissue transaminase antibody, IgA levels, plasma peptides, like if we are suspecting calcitonin, and in case of a neuroendocrine tumor, chromogranin A, gastrin, somatostatin, VIP, etc. And urine metabolites like histamine and 5-hydroxyindoleacetic acid, metanephrines, then ACTH stimulations, immunoglobulin, serum protein, according these are the second line of investigations that may be considered. Then glucose hydrogen test, breath test for SIBO and others, serum protein electrophoresis and immunoglobulin electrophoresis in case of a suspected hypogammaglobulinemia, and again diet exclusion, food exclusion test has been mentioned. Then if suspecting bile acid diarrhea, then bile acid binding agents, a trial of bile acid binding agents, and in case of SIBO, antibiotics, empirical antibiotics. So
is there a way of testing for bile acids in stool?
Bile acids in stools. Yes, cholesterol trial.
And when do you do a serum tryptase level for diarrhea? Why do you do? Is there a test called serum tryptase? Is there a role of doing allergen tests for diarrhea?
Allergen test. Okay, so.
Is there a role of absolute eosinophil count in diarrhea?
Sir, if suspected eosinophilic enteritis,
Okay, please proceed. I mean, they are just pointers for you to jot down and read regarding the rationale in checking out serum tryptase, absolute eosinophil count, validate whether it's a bile acid diarrhea, how do you investigate a bile acid diarrhea. All these things you can go into the details again. I mean, it's your second year. By finally we'll finish it off. Please go ahead.
So basically, in the management of secretory diarrhea, we need to exclude infections, and once that is done, structural diseases may be excluded by relevant like bowel radiography or endoscopies or CT scan, and biopsy with the aspirate, small bowel biopsy with the aspirate culture, and then in whatever according to the finding, we may go for further specific test for the.
So you mentioned small bowel biopsy when Madam asked you about the infective causes of small bowel biopsy. Could you just enumerate all the conditions of diarrhea which can be diagnosed by a small bowel biopsy, especially a duodenal biopsy?
Sir, in case of lymphoma, sir, small bowel lymphomas.
Yes.
Then
you have to classify it as diagnostic.
Only if you are lucky enough, you will get it, because lymphoma is not that diffuse. Okay, so diffuse mucosal diseases affecting a large segment of the intestine, you can pick up by a deep duodenal biopsy. Earlier, in our time, it was jejunal biopsy, but now it is endoscopic duodenal biopsy. Okay, so usually it is diffuse mucosal disease which is picked up, and there again there's a classification. The jejunal or duodenal biopsy is diagnostic of, where diurnal biopsy is most probably, and like that there's a classification given in a textbook.
Which are the conditions where it's diagnostic?
Madam, in case of Whipple's disease,
A beta lipoproteinemia, A gamma globulinemia, lymphangiectasia. These are all very diagnostic. You will not get in any other this thing. So just a duodenal biopsy will give a clue. So you must know which are the diagnostic tests which we can almost make a diagnosis by duodenal biopsy. Then those which may be probable.
I've made a slide of it.
Okay, keep talking now. Keep speaking.
You made a slide, but then how you are not able to answer? I don't. Why is that, Ayisha?
Not able to read.
Okay, right.
So this basically the conditions which can be diagnosed by duodenal biopsy and their characteristic findings which can be seen on histology. Conditions like A beta lipoproteinemia and hypo-beta lipoproteinemia, there will be lipid accumulation and vacuolization of enterocytes, collagenous sprue, that may be collagenous band and below the atopic epithelium. Then infections like Mycobacterium avium complex infections, we will get to see the acid-fast bacilli and presence of giant form cells. Amyloidosis also can be diagnosed by Congo red stains and apple green bifringence in the polarized light. Then in case of a Crohn's disease, again, as we know, granulomas and characteristic inflammations. Then eosinophilic gastroenteritis for eosinophilic infiltration, lymphangiectasia, presence of ectatic lymph vessels, lymphoma, clonal expansion of lymphocytes, and mastocytes. There will be diffuse infiltration with mast cells. Then parasites, basically Giardia lamblia, strongyloids, and coccidia, which may be seen on histological examination. Then coming to inflammatory diarrhea, which is basically caused by mucosal disruption and inflammation. So the conditions are usually inflammatory bowel disease. It could be because of infections, mesenteric ischemia, pseudomembranous enterocolitis, radiation enteritis, and sometimes even neoplasia can cause a inflammatory diarrhea. So basically, we have to exclude the structural disease by imaging, CT, MRI scopies, and exclusion of TB, parasites, and viruses. Now, coming to chronic fatty diarrhea, steatoria is basically disruption of fat solubilization, digestion, or absorption in the small intestine. So basically, it could be caused by conditions like defective mixing, as in case of a gastric resection or GI motility disorders, reduced solubilization of fat because of low luminal concentration of conjugated bile acids, decreased lipolysis as in case of exocrine pancreatic function, decreased mucosal absorption as in case of celiac disease, or it could be because of disturbance of intracellular formation of chylomicrons or lipid accumulation as is a pathology in beta-lipoproteinemia or hypobeta-lipoproteinemia. So here,
So I will just ask you, how will you differentiate between fat maldigestion and fat malabsorption clinically?
fat maldigestion and malabsorption.
Because
So,
steatorrhea is
the
typically
passage of
because we include both in steatorrhea. The class is steatorrhea, which is described actually celiac disease, profuse frothy, fault smelling, and all those things. Okay. In a typical chronic pancreatitis, where there is fat maldigestion, you actually don't get this type of frothy, watery, and all. You get actually greasy stools. Okay, greasy stool, or patient may even say that the perianal region is very greasy when they clean up, or sometimes they may even find oil droplets dropping down from the anus. Okay, or oil droplets or oil things sticking down the sides of the feces. So, greasy stools. That may be the only indication of fat maldigestion. Okay.
Now, in the endoscopies, when we do, there may be diagnostic clues in like there may be scalloping of mucosa and reduction in number of mucosal folds, as in case of celiac disease, and there may be a presence of aphthe, which is suggestive of Crohn's disease. In case of lymphangiectasia, there may be small diffuse whitish yellowish lesions, and we may be able to find endocrine tumors like duodenal gastrinoma, somatostatinoma, or ampullated tumors during this. And we can also go for a duodenal biopsy, which can help us reach the diagnosis. Then imaging to consider will be small bowel follow through or enteroclysis, where mucosal or mural irregularity can be made out, or if there is a focal or diffuse abnormalities which are predisposed to small intestinal bacterial overgrowth. And in abdominal CT will help us to look for focal lesions, presence of lymph nodes, abdominal lymph nodes, or any structural disorders of the pancreas in case of a chronic pancreatitis and diarrhea secondary to exocrine pancreatic insufficiency, presence of any pancreatic duct obstruction by tumors or hormone secreting neuroendocrine tumors. Then abdominal MRI also can give us diagnostic clues in the form of segmental bowel wall thickening, presence of mesenteric inflammation, cobal stoning, or ulceration, as in case of Crohn's disease. Then in case of celiac disease, there will be small intestinal dilatation.
So do you think these things are only
thickening.
found out by MRI? Your presentation looks
No,
as though
sir.
CT will certainly find certain disease and MRI will certain disease. No, there's a lot of overlap between these two investigations. Okay, there's a lot of overlap between these two investigations, MR and the CT. And ideally, we should do a CT enterography if there's a diarrheal disease suspected, especially if you are suspecting a bowel disease. And you have put abdominal ultrasound as the lowest. In the hierarchy, if you are doing an ultrasound, I think you should do it first, followed by CT or MR. That's the order in which it is done. Okay. Proceed.
Vanderkamer's test was the
this is the test which
fat
ma'am was
estimation
asking for.
test. Yes,
what is the name of the test for which you will do fecal fat estimation? 1D camera test. Okay. This is actually 72-hour fecal fat estimation by collecting stools for 72 hours after a fat load of 100 grams of fat per day. Okay. There's one more test known as acid steatocrit test, which is done in most of the centers. Now the 72-hour fecal fat is very cumbersome and difficult to do. Practically only few people in this world may be doing this. Maybe CMC will do, they are doing in Calicut Medical College. So we have trained our person from CMC. He is capable of doing, but he doesn't do it now. Acid steatocrit is the simplest technique which is done nowadays in most of the places. Okay, next slide.
So for fatty diarrhea, we need to exclude the structural diseases and then exclude the pancreatic exocrine insufficiency by secreting test or stool chymotrypsin activities. So that's.
Okay. So over to Dr. Sunil.
Ayisha, that presentation was extensive, and most of the answers which the questions was raised on came in your slides. But this is where we suspect that there is always a cut and paste where you have not gone into the slide. So each of these presentations, when you do, I'm sure that go and revisit all these things and make sure that you learn it also. So when you learn it, it will be much easier for you because chronic diarrhea is almost bread and butter for the gastroenterologist. Wherever you go all around the world, chronic diarrhea is something which you have to work out, and sometimes you spring up surprises. One of the things which possibly should be included is the immunosuppressed patient. I don't know whether in this slide, something which is slightly different because HIV diarrheas, the diarrheas which present with the immunosuppressed are slightly different from all these presentations. So it might be worthwhile using it as a separate topic also. It is, thank you, Ayisha. I mean, you made a good effort. We could hear your child also banging in the background, asking for mom. I don't know whether it is your child, but we could hear a loud bang saying "amma, amma, amma" and all these things. So it is nice that you took time to present it. Thank you very much, sir. I think you should,
Ma'am, your comments.
elaborate on.
I'm done sufficient of comments. No problem.
Okay, I think we are already very late. We will conclude the session.
My only suggestion is, like, I wish you could have just focused on bloody diarrhea today, no? And then when they have that watery diarrhea, you could have focused on that. Otherwise, I mean, one is theory, but I wish you had focused elaborately for half an hour, 45 minutes only on this particular case, bloody diarrhea or inflammatory diarrhea. What are the causes, approach, so that you know, because we discussed about that case, but suddenly we went into all types of diarrhea, but that's theory. So, I mean, I stand to correction on that, but I think it's always nice when we have just a correlation between what we are discussing and the theory on that. Then that way, most of us will remember also what is being missed and what is to be discussed.
I think in future we will discuss bloody diarrhea separate and watery diarrhea separate, acute diarrhea separate, so that each will be discussed separately, so that we will have devote good time for these things rather than doing everything together. So as we told earlier, Dr. Ayisha has done a good job. It is extensive coverage, but only thing is that you have to read a lot and make the presentation so that it will stick with you for the rest of the life. So you have done a great job. And also, as Dr. Sunil said, with the kid just in the background asking for Amma, I was feeling little upset also. Young kid not able to see the mother and banging on the door. I was feeling little upset. That's why I did not talk for quite some time. But anyway, you have done a good job. And sorry for troubling you. But it's part of this study. You have to do this. So thank you. And over to Dr. Hari. Hari, are you there?
Yes, sir. Yes, sir. Today we had a wonderful session on approach to area. I would like to thank Dr. Sunil Mathai, sir, for chairing today's session. I thank Professor Jayanthi ma'am and Professor Varghese Thomas, sir, for moderating the session in such a wonderful way. And I also like to thank our ISG of Kerala office bearers, Dr. Roy J. Mukda, President, and Anthony, sir, Secretary, for providing a platform for such an academic session. I also thank Dr. Ayisha for presenting this case and the discussants, Dr. Zhumu and Muthukrishanan, for discussing it in such a wonderful way. I also thank all the attendees for participating in today's session and making the session a success. Thank you all. Have a good night.
So good night, Dr. Sunil.
Good night. Good night,
You
sir.
will join us
Thank you,
for much more sessions frequently. Okay, good night to all of you.
Good night. Bye-bye.
Bye.
Good night. Bye.
I am closing the session.